Hi, and welcome back to Anesthesia Tech Pearls. This lecture is about positioning a patient while under general anesthesia. And what we're going to talk about is not only the proper patient positioning, but the function and location of major nerves, how these nerves become damaged, and the results of those damaged nerves, and how we can, of course, prevent it. So let's go ahead and get started and tell you guys, I must have been writing this sometime around Halloween because I got into a skeletal theme. So I tried to keep skeletons throughout it. I don't know what I was thinking, but enjoy the humor. It's supposed to be to liven it up. So here's Da Vinci's, sort of Da Vinci's, of course he didn't draw on the skeleton, Da Vinci's man. This is a nice supine position, and this is how I would want all of my patients. So why would I change it? Why would I position a patient in any other way other than nice supine? And the short answer is because the surgeon asks us to, or tells us to. We have to for that particular surgery. It's not because I want to go prone or I want the patient to be in some strange position. It's because we need to allow for the operation. So peripheral nerves appear to be particularly vulnerable to injury during positioning, the actual moving of the patient, and also when the patient is sitting under general anesthesia. They of course cannot move, so you can have an ischemic injury from lack of blood flow, or a compression injury, or a stretch injury. And just for fun information, of course, it is always anesthesia's fault when a nerve gets damaged. No one blames the surgeon because it wasn't him or her who cut the nerve. It is us who prevented the nerve from becoming damaged. So according to information from the American Society of Anesthesiologists, the ASA, closed claim database, a significant number of anesthesia-related claims involved nerve damage. So of more than 1,500 claims reviewed, 15% were anesthesia-related nerve injury. And I gotta tell you, it kind of makes me feel like this, you know? Keep calm and blame anesthesia. It wasn't my bright idea to put the guy in this weird position, but nonetheless, it is our job to protect the patient. So let's see how we can do that. And again, trying to stick with the skeletal theme. Here's the skeleton laying in a nice hammock. This is the nice supine position. And the supine position, which is the most commonly used position for surgeries, is generally the safest position. And it's not associated with dramatic or catastrophic position nerve injuries. But even this position, however, can lead to post-operative ulnar nerve neuropathy. And I'm going to show you where the ulnar nerve is in a minute and how to protect that. And the most common position-related nerve injury of all time is ulnar nerve neuropathy. Now, listen to what I just said. I love statistics, right? Because they kind of can lie to you. If supine position is the most common position, and the most common nerve injured in the supine position is the ulnar nerve, then it would come to say that that ulnar nerve is the most common position-related nerve injury. Now, you gotta watch out for people when they say things, you know. It's not that the ulnar nerve is more sensitive than the other nerves. It's just that we're in that position that causes it to be damaged more often. So this is the supine position. And when we're laying flat on our back, you can either have your arms out like they are in this picture, or they can be tucked up to the side, and we're going to review both. Now here's a little trick of the trade. The ulnar nerve, which goes right behind the elbow, the under part, like the outside of the elbow, not the inside where you draw blood, but the outside of the elbow. That is where it is most vulnerable, right in that joint. So if you put the hands to heaven, put the hands out, supinate the hands, supinate, I guess, tomato there, you rotate that elbow joint just enough that it will be less vulnerable. And of course, pad under the arm. But let's review the pressure points that are in the supine position. So the pressure points that we're worried about are the head, the occiput, the pressure points of the scalp. If I don't take care of the pressure points in the scalp, say I'm using those, goodness gracious, I hate those, what are they called? Not the foam, but the gels. The gels, which are totally, in my opinion, unforgiving and should be thrown away. But, you know, that's my opinion. I'm sure lots of people use them. I do, but I don't like them. They can cause pressure points on the scalp that result in alopecia. Now, probably the foam can do that too, but here's a good point. If you have a long surgery, and I do mean greater than 3 hours, upon occasion, the head should be rotated from side to side. And of course, protect your airway when you do that. Grab onto your tube. move the head from side to side. You have, of course, the vertebrae, the scapula. We talked about the ulnar nerve, the wrists, the sacrum, the heels, and the toes. So supine pressure points again, the head, the vertebrae. Of course, I'm thinking the elbow, the humerus, I guess, but the elbow is where you really need to look out for. She should not be wearing jewelry. I don't know why she is. Make sure if her hands are to her side that the fingers are splayed out against the thighs. You don't want them tucked under people's bodies. I find that all the time. Put a pillow under their thighs, and here's a good trick. Make sure that the heels are off of the bed to relieve pressure. I don't care if you put foam or pillow, and here do not allow those drapes to be pulled down by instruments putting pressure on the toes. So tucking the arms, just to go over tucking the arms, there is always for some reason a rush when we put someone to sleep. Then the surgeons are rushing to put the Foley in, rushing to get the person in position, and it's hysterical to me because when they're sewing that incision closed, I never say, hurry up, I need to start my wake up sequence. What's wrong with you? I never say this. I wait. So I'm always wondering why everything has to be so fast. Let me take a little sip of water. Hang on. Pardon me, my water bottle is full. Make a glug 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 sound. So when you have somebody quote unquote helping you position, you have to watch them. And you have to walk behind and double check them. So I've had it where I've just gotten the tube in and I'm taping my tube and someone comes next to me to quote unquote help me and starts tucking the arms in. Now we know the most vulnerable nerve injury in the supine position is the ulnar nerve. We know this. And you want to have this ulnar nerve, this elbow, padded very well. I don't want the padding between the body and the arm. I see this done all the time. I don't want the padding so much on the wrist. I want padding, I need padding on the elbow. So you want to make sure that there's no hard surface touching the patient. The elbows are padded, and when they tuck the arm in with the drapes, with the sheets, that the fingers are splayed against the thigh. The fingers are out, thumb is facing up, fingers are straight out, they're against the thigh, and not tucked up under their body. You'll come around, you'll check that quote-unquote nice person helping you to tuck your arms in, and you'll find that hand all tucked up under their body, and the cushion, the nice thing that's supposed to help protect the ulnar nerve is stuck up in their armpit instead of between the bed surface and their ulnar nerve. So that wasn't a big help at all, was it? So here we are, nice and tucked. And this is actually a really good job, except the fingertips should be splayed out. They should be pointing down to their toes. You don't want the hand crunched up. Surgeons lean against these bodies. They put pressure against it. This needs to have a cushion. I know that they're on a cushioned mattress. I can see that. I still get a piece of foam and put it right under there and under the first draping so it's all tucked up in here and it won't migrate. Walk around, check both sides. Obviously, it's just a model. Okay. Other than that, he doesn't have a real pillow, which is fine. He's using a sheet. I highly recommend getting a cushioned something under his head. He doesn't have a pillow under his thigh area. This would reduce lumbar strain, and I can't see the toes. So always remember all your pressure points. Now I included this picture because, it's just something I pulled off the web, but look, everything here is wrong. Everything here is wrong. This man is not protected one iota. He's laying on a hard metal surface. There is nothing under the ulnar nerve. He's touching this arm board that is extremely hard metal. His toes are not protected. His heels are not protected. There's no pillow under his thighs. And I don't know what that is, but it doesn't look like a pillow to me. It looks like a plastic surface that he's on. So every pressure point in the supine position is being exposed. His head, his shoulder blades, his ulnar nerve, his lumbar is not protected with a pillow under his thighs. His heels are on a hard surface, and, well, yes, his toes are free. Well, there you go, except they're pressing against this board, which is not cool. And this is the other extreme, right? She's gelled up from one end to the other. She's so protected, it's insane. I've never seen this before in my life. But absolutely, she has the gel that I don't like, but it's okay. Under her head, remember if it's a long surgery to rotate the head back and forth. Her head is in a nice neutral position, so they protect her vertebrae. She's under gel here, and there's the ulnar nerve under here, and I'm going to show you a picture of it in a minute. Yes, she's like so gelled, everything's perfect. So the ulnar nerve, the most commonly injured nerve in the supine position, the risk of injury is greater if the elbows are flexed greater than 90 degrees. So what do I mean by that? If your arms are out and not tucked up to your side, but they're out on arm boards, have it in a neutral position, less than a 90-degree angle. If surgeons, and they want the arms out of the way, start jacking the arm up, and it's a greater than 90-degree bend, you can stretch the ulnar nerve, and you can also stretch the brachial plexus. So just be careful not to go greater than 90 degrees. Long surgeries, great risk of nerve damage. So what you want to do during long surgeries is to somehow move the patient a little bit. If it's lasting longer than 3 hours, just reach under the drapes and gently move the arm a little bit up and down just to bring blood flow back into it. If you're in a different position or a lateral position where the arm is down, I put the pulse socks on the dependent arm so I can get a good reading on that. That will come up later. And the pressure point on the posterior portion of the elbow is exactly where the ulnar nerve is most vulnerable, and here it is. This blue line is the ulnar nerve, and you can see it run right through this joint, and that's your elbow, and that is where it is most exposed. This is the medial nerve. All right, so what happens, right? Always curious if I don't protect the ulnar nerve, or if there's an ischemic event just from pressure on a metal surface, what would happen? Well, I mentioned very briefly the medial nerve, and we'll go through that, but the ulnar nerve, you would lose the ability to flex your fingers or extend your fingers. So the proximal, depending on what part of the ulnar nerve gets damaged, if it was the proximal ulnar nerve, you can no longer flex the fourth and fifth digits. These, your ring finger and your pinky finger, you can't bring them in. So you'll have your pinchers, you can use the thumb and your first two fingers. I know this seems wrong, but it's so true. So the ulnar nerve, if it's the distal ulnar nerve, then you can't flex them. You can't open them up, the last fourth and fifth finger. By contrast, if it's the medial nerve, and I showed you briefly what the medial nerve is, it's just the other two fingers. The first and second fingers you either cannot extend or you cannot flex. That was interesting. Sorry, something just banged on my house. I'm going to pause this for a minute because I'm a little curious. Here we go. Sorry about that, guys. So just to summarize all of the supine positions, you can have the arms out or the arms tucked. The forearm should be in a neutral position with the arms tucked at the side. Flexion of the elbow may increase the risk of ulnar nerve neuropathy, but there is no consensus on an acceptable degree of flexion during the perioperative period. When we have our arms out, do not allow the arms to be flexed greater than 90 degrees. Prolonged pressure on the radial nerve in the spinal groove of the humerus should be avoided. Extension of the elbow beyond the range that is comfortable during the preoperative assessment may stretch either the medial or ulnar nerve. And let me give you a perfectly good example of that. And that happened recently to me, where I had a patient who had a rotator cuff tear. This man is not capable of moving his arm past a very short range of motion. Beyond that range of motion causes him severe pain. Now he's been holding this arm in that position for months. You can get a frozen shoulder from doing that. We're not going in to surgery to fix his rotator cuff. We're going in for a different reason. So I had to protect his arm. I had to protect the limitations he had. So we gave the surgeon two choices. Either it could be out on the arm board, but only to this degree that the man could do while awake, or we can tuck it up against his body. Again, that is the degree that the man could perform while awake. You have to obey the patient's mobility restrictions that they can clearly do to you while out of anesthesia. I can't imagine anyone giving you an argument about that, but if they do, please hold your ground, because remember the lawsuits. Who's going to get blamed? It's going to be you and me. It's not going to be that surgeon who jacked their arm up. It's going to be you and me. So, I'm sure there's more. Hang on. Supine, arms tucked. secure the arms close to the patient's sides, palms touching the sides, have everything on a nice padded surface. This can be difficult to achieve if you have a BMI greater than 26. As our population, especially the US population, has grown in size, our OR tables, I think, have remained the same size. So you have to avoid the OR metal table, the surfaces that go along the side. Extra padding is needed. Just be very careful if you have a morbidly obese individual and they put on the seat belt and they tighten it down, that it needs to be padded around. I recently had someone, and it turned out fine, but the actual fat folds came down and got pinched between the metal rail and the seat belt. And I didn't see this until afterwards. Fortunately, it was a short surgery and nothing was harmed, but I can tell you right now, whose fault would that be? It would be anesthesia's. So sometimes extra padding or protection around the elbows is needed. The humerus head, the top of the shoulder, the humerus head can compress the brachial plexus when arms are tucked. And I have a picture of the brachial plexus coming up, but I'm going to tell you really quickly. It is a four-branched nervous system, well, not a nervous system, a four-branched nervous bundle of nerves that comes off of C5 to T1, and it runs right, part of it runs right under the clavicle and then goes over the first rib, and it goes, and another part of it goes right around the humerus head. So if you have in the supine position, sometimes we'll put on, when they tuck the arms, they pull the arms down and cause the humerus head to be pulled down. If you just move your own shoulder down, you can feel a difference in it. This can pinch part of that brachial plexus nerve, and you'll have constant numbness and tingling and pain in your arm for the rest of your life. When you have a stretch injury on a nerve, it doesn't recover. It is truly forever. These pictures I'm showing you, these people will never recover from this. This is how they're going to be the rest of their life. Nerves are not very resilient in that. So in summary, in this supine position, the pressure points we're looking for are the head, the scapula, the ulnar, the wrist, the sacral, the heels, and of course the toes. You want the head in the neutral position, or in the position that's favored by the awake patient. Use a pillow or a pad to avoid alopecia, which is a fancy word for loss of hair due to pressure, and to ease the stress in the neck. Put a pillow under the thighs to ease pressure in the lumbar spine. You want a cushion under the neck, well, just to avoid alopecia. So pad elbows and supinate the arms to the forearms to the sky if the arms are out on arm boards. If the arms are tucked, I want the palms against the thighs, fingers facing the toe, thumb up. Do not allow those hands to be tucked under the body. This would cause an ischemic event. They would lose pressure they would lose blood flow just from the pressure of their body laying on them. Remember, you can't move when you're under anesthesia. You want to monitor the heels for breakdown and ensure that the legs are uncrossed to avoid a compression of the blood vessels into the lower legs. Pillow under the knees. Pad all bony promises. Special concern to the morbid obese patient we talked about. Moving into the supine position may result in increased, of course, oxygen consumption or cardiac stress, and of course pulmonary artery pressure that is beyond the patient's limits. So when I interview a patient that is BMI greater than 26, I'll ask them, how many pillows do you sleep on at night? And some people flat out tell them, I haven't slept in a bed in years, I sleep in a Barker lounger. I'm like, okay, well, then you know how you're going to have to go to sleep with this patient and try to obey that. Not all surgeries can be done in that position, but at least try to get them stable enough and in enough of a V shape where you can maintain their cardiovascular system. All right, I think that's enough about supine. I could go on and on all day. So just to review the ulnar nerve damage in this screen that you're looking at, if you have ulnar nerve damage, you'll have loss of sensation, especially in the ring finger and little finger, loss of coordination in those fingers, constant pain, it'll be tingling or burning or both, hand weakness that worsens with physical activity, complete loss of hand grip, strength. So definitely something to be avoided. All right, so this is the prone position. Okay. Clearly, she is not prone there, but that's as close to a prone and skeletal theme I could do. This is a true prone position, and this is how I like to do mine, with this nice You might have a prone view that's either like this, it's all cushy, or you might have one that's more like a massage pillow that has a mirror underneath. And the mirror is really nice because it makes it a little bit easier for us to check the eyes and the nose and the lips and make sure everything has no pressure behind it. So peripheral nerve injury is possible, of course, in the prone position, and the brachial plexus is the most susceptible to injury in several places when the patient is in the prone position. Remember, we talked about the brachial plexus. It branches off from C5 to T1. I do have a picture coming up. Pressure on the humeral head can compress the brachial plexus if the patient's arms are hyperabducted, if you're put up into like the Superman view, or if they tuck them on the side and they pull the arms down. Either way is going to hurt that brachial plexus. And when you see the webbing, it'll make perfect sense to you. The brachial plexus can also be compressed against the first rib, secondary to extensive force on the clavicle. Say you're using shoulder blades to hold them, not shoulder blades, but braces, shoulder braces to hold them in place if you're going to go into steep Trendelenburg. In positioning the upper extremity, the arms at the shoulder must be at a 90-degree or less abduction. In other words, I put my hands on this person's shoulder and I push, and I want it to be completely straight across. I do not want to feel their shoulders up in their ears like they're wearing those earrings. That's not neutral. You want to be in a very neutral spot. Walk to the side. Look at their neck. Is their neck in a nice neutral position? You don't want the head jacked back. You have to be careful in positioning these patients on devices with posts, such as the Jackson frame, which may cause compression on the femoral nerve or lateral femoral cutaneous nerve. These are in the legs, of course. Because the face, the breast, and the genitalia are of particular risk for compression injury, careful attention must be paid to the initial positioning with frequent checks to ensure that shifting has not caused damage. Inadequate support of shoulders, which allow them to sag anteriorly. Say these shoulder rolls were not up close enough. These shoulders would sag down. This would cause traction on, you guessed it, the brachial plexus. So if you see that happening, if you see these shoulders sagging downwards, then you have the crew come back in and move these shoulder rolls back up into position. Extending the arms over the head compresses the brachial plexus against the clavicle and the first rib. Now let's talk about the face here. There's a lot to be talked about with just this face down in this face mask. There is an opening for the face to go to. When you put the patient in prone position, you must not only reach in to feel that everything's nice and free, you have to look. When you look, you must visually see that the eyes are free of pressure. It's not necessarily pressure on the eye that causes people to become blind, because that is the side effect. It is the compression and the ischemic event of the retinal artery that causes them to wake up, and they'll have photophobia and they will be blind the rest of their life if you have pressure on the eyeball. Pressure on the nose or the lips. Make sure the ET tube slides out evenly from the side here. Of course, this guy isn't intubated. So it's easy ventilation, that it's not being pushed down. If you have it so it's being pushed onto the bed, you could accidentally right mainstem a patient. It's not a nerve injury, but it's something to be aware of. All right, so prone positioning concerns. And you know me, guys. I talk everything, then I have to show you and repeat it. So prone positioning concerns the brachial plexus damage. We've talked about that. The vision changes are blindness from pressure from an ischemic event on the retinal artery. Difficulty ventilating. That would be not a nerve damage, but something to talk about. And it's really from poorly positioned chest rolls. Cardiac output. Again, poorly positioned chest rolls. The breast and male genitalia. You must protect our patients so they don't wake up with a compression injury. So here's the brachial plexus. So here's C4, but it comes out of C5. It actually is below, it's this C4 up here. Comes out of C5 all the way down to T1. And you'll see it's labeled the superior, the middle, and the inferior. And then these branch off. So it's kind of like a webbing that comes out. But you'll see here's the clavicle. You see some are over it, some are under it. And then the first rib right down here. So you see how he can get pressed? The inferior portion of the brachial plexus could get pressed between the clavicle and the first rib, that branching off here. Then the humerus head here, See, that's part one of the branchings of the posterior part of the brachial plexus. If you had let the arms be pushed up, it can be pinched, or pulled down. They all must be in a neutral position. And what would that cause? The burning, the tingling all the way down the arm, the loss of hand strength in the arm. And it's not curable. Most times it never comes back. Here's a better view of it. I'll let you look at that for a minute. I'm going to take a sip of water. All right. All right, so diminished vision or blindness, sustained pressure on the eyes in the prone position can result in reduced vision or blindness. This is the result of retinal artery occlusion. This means an ischemic event. It means where the blood flow hasn't been able to happen. Pressure on the eye or the forehead closes the retinal artery and reduces blood flow. Ventilation. Again, I love these pictures with these beautiful chest rolls. These are the chest rolls I usually work with, right? Who gets these? I would love to have those. I'm sure I would. But you have to have the stomach free in this area and the genitalia. You want the genitalia not being compressed into these rolls, as well as women's breasts. You don't want them being pushed out to the sides. Make sure they're in the neutral position. So if the stomach is free, it helps with ventilation. If these are too close together, it will also it'll make it difficult to ventilate, and it's going to make a harder cardiac output. You're going to have a shunting of the blood up, and when the heart has to work harder to push out. Just a little side note, I know it's not nerve damage, but just a positioning concern. I'll try to stick with the theme of nerve damage here. So the poor cardiac output, pressure on the chest from poorly placed chest rolls can result in an increased intrathoracic pressure, thus reduced stroke volume and output. So again, trying to stick with the skeletal theme. It is okay to go prone without a face mask, without that prone view. I always use a prone view, but it totally is fine. But then you have to add to your pressure point the cheek and the ear. Be very conscious of that. I also think it's harder to maintain a neutral position. If I was going to do this without the chest rolls in here or without the face mask, it better be like a super short thing, like maybe an EGD. And that's maybe 10-15 minutes. That would be fine. So you're going to look at the shoulders, the humerus head, make sure it's not being pushed up or pulled down. The women's breast, make sure that they're not coming out onto this table and being hurt or compressed up tight. Men's private parts. You want the knees padded and, of course, the toes. All right, we're going to move forward to our beach chair position. Beach chair is also known as Fowler's position. And there are several peripheral nerve injuries that can happen here. And there's lots of other concerns that I do feel warrant us touching on them. So the big nerve damage that's possible is, of course, the brachial plexus. And it is susceptible to injury in several places when the patient is in this position, because we're usually working on a shoulder or a elbow, usually shoulder. And we jack up one arm really high, and you just have to be careful that that doesn't pull down on the brachial plexus. If you are allowed to do if they're not going to use a tourniquet, I sometimes ask to put the SAT probe on the operative arm. That's usually accepted, but a lot of times they're using a tourniquet, so it doesn't work. But if you're using a shoulder, it'd be awesome. But let's talk about a VAE. Now, I don't know if you've all ever reviewed this. I'm going to tell you what it is. It's a venous air embolism. So if you're sitting in the beach chair position, you have to think about where the blood pressure cuff is as well, and we'll get to that in a second. But a VAE, a venous air embolism, you can entrain air into the vascular system. Say they're doing this for a cranie and they open up the head. What else could it be? Actually, anything. I've only had this happen to me once. I'm going to tell you in the textbooks how you're supposed to handle it, and then I'll tell you how you handle it in reality, because unfortunately textbooks aren't reality-based and it just doesn't work that way. So a venous air embolism, when you entrain air into the vascular system, your end tidal will instantly disappear. But if you had a central line in place, which we don't put a central line, quite frankly, in everybody that goes into Fowler's position or beach chair position. If you had a central line in place and you had a probe on the man's chest, you would hear, on the patient's chest, you would hear a pinwheel murmur happen as the air is entering the heart. This is textbook, guys. You're supposed to instantly put the patient down and flip them onto their left lateral position. this would, in theory, trap the air into the right side of the heart, and you'd be able to pull the air out through your central line. And as we all know, a central line tip sits in the SVC, which is right outside the right atrium. Now, in reality, there's no way that would ever happen. Because you know how long it takes you to get into this beach chair position? To actually put somebody down and flip them lateral? So in reality, what happens, since we don't have a central line and we don't have the monitor on their heart, first your end tidal disappears. As soon as that happens, tell the surgeon to please flood the field. That means put fluid in the field. They just pick up warm saline and dump it in the field, and that would prevent more air being entrained. You do your code, they try to tie off any vascular systems that are open, and that's only happened to me once. And you move forward. Now the blood pressure cuff, the concerns of where the blood pressure cuff, so it kind of determines what you're reading. And the upright position can lead to potential cerebral injury due to hypotension. So consider the scenario where the blood pressure cuff is either on the arm or even worse, the leg. When the patient is in the upright position, the pressure measurement should be performed at the level of the brain, right? So because the larger hydrostatic gradient exists between the brain and the site of the blood pressure cuff measurement, you really don't know what your blood pressure is. You want a mean of like 75 in the head to have adequate perfusion. So if you're taking the blood pressure on somebody's leg, your hydrostatic pressure variation is so different from reality, you're not accurately perfusing the head. So if you see someone that's going to go into Fowler or beach chair position, immediately put a NeoDrip in the room. This patient's going to need 2 large bore IVs, and they're going to have a NeoDrip running the whole time because we will push that pressure up to prevent them from having a cerebral injury. But going back to the nerve damage, so we have hypotension, right? So the upright position can lead to the cerebral injury due to hypotension, and you want to push the pressure up just because the hydrostatic gradient is very, very different. Incorrect head positioning, going back to the nerve damage, the cutaneous neuropraxis of the nerves have been attributed to direct compression of the nerves of the head rest holder. Now let's look back at that picture. One more. No. I want that picture. I guess I can't zoom into that. If you see the head rest holder, you could have direct pressure onto the face, onto the chin. And if this migrates down, you could have pressure onto the eyes as well. So you want to put protective goggles over the eyes. And going back in here, we'll get through this, guys. I'm taking this a little bit longer than I meant to. I'm sorry. So incorrect head positioning can also cause compression in the neck, compression of nerves from the headrest. We talked about using the protective goggles. Make sure those are in the room as well. And the eyes, pressure on the supraorbital nerve from the restraints are from actually the goggles. Could result in injury to the nerve, resulting in eye pain, forehead numbness, and photophobia. So you want to keep also the neck in a neutral position. Neck flexion. The neck veins may be obstructed when the neck is excessively flexed, so you want to keep the head and neck in line with the spine. And again, we are responsible for this position. So when you take a patient, first you put them to sleep laying flat. They will position them up into the Fowler's or beach chair position. We instantly see a drop in our blood pressure, and we're going to treat it because we have that NeoDrip in line. You have to walk around the patient. The entire room is part of this decision-making process. Walk around the patient, and everyone will decide if the patient is in the proper position. All right, so lateral. Lateral position is either, it's totally on your side. It can be either right or left. So what are the risks? Neuropraxia, of course, of the brachial plexus. This guy keeps coming up, So what do we do to prevent that if you're in the lateral position? We put what's called an axillary roll. Now, it's not put in your armpit, the axilla. It's put on the rib cage, and it's to prevent the compression of the brachial plexus. And the other thing you have to do is put your SAP probe on your D pendant on the downside arm. Radial nerve palsy on the non-surgical arm can result from an ischemic event, from that pressure of the whole body laying on it. It can also be a result from a lack of padding up the arm resulting in compression of the radial nerve. Lower leg peroneal nerve, so down here if you don't have a pillow between the knees, due to compression against the operating table as well. All bony prominences must be padded. The most common injuries associated with the lateral position used in both shoulder and arthroscopy hip position. So if you're doing a shoulder or a hip surgery, are damage to the brachial plexus. It can result from excessive traction in the surgical extremity, the pulling on the arm. So what are they going to do? They pull down the humerus head and they pinch off part of that brachial plexus. Or from prolonged pressure on the contralateral, the downside axilla. To prevent this, the axillary roll should be placed down below the axilla, actually on the rib cage. Okay. Proper placement of the axillary roll in the under the rib cage and not in the axilla. I keep saying that because I don't know why they called it an axillary roll. I mean, why would you misname it like that? All right. Remember, your patient's asleep, so they're not going to tell you they're in pain. And I keep saying it, the positioning is our problem, right? All right, so I keep saying the word neuropraxia, and I don't think I've ever defined it. It's just a 50-cent word that means failure of nerve conduction in the absence of structural change. So when you say neuropraxia, it means it didn't get cut, it didn't get stretched, but the nerve is damaged. It's usually from a blunt injury, a compression, or ischemia. Okay. So the brachial plexus neuropraxia results in the patient feeling a burning, painful sensation in the neck of the involved side. This also can migrate down their arm. The pain is caused from compression on the cervical roots. The burning may radiate down the shoulder and down the arm into the hand, and it may be associated with numbness, tingling, and weakness on the involved side. I know, it makes you want to not put anyone in a lateral position. All right, lithotomy position. This is the position, usually we do this surgery if you're going to go somewhere in the genitalia. So you begin in the supine position and you raise and abduct the legs. It's very important to raise and abduct the legs together. You don't want to do one leg at a time and do the other leg because you can actually stretch the nerves. And I'm going to go over those 5 major nerves here. So you place the arms either on the abdomen or you can tuck them onto the patient's sides. And we've talked about tucking arms onto the side, how you want the hands against the thighs, the thumbs facing up, and the fingers splayed against the thighs. The buttock should be even wherever the bed breaks. This makes it risky for us because when we pull that bed frame back up, we could pinch the hands, the fingers, and part of the buttocks. So you have to be very careful when repositioning the patient at the end of the surgery. So you place the legs and feet in stirrups. Here they're using like these fins. I love these things. They're awesome, but sometimes you still use stirrups. They're like candy canes. Those are very, very dangerous. You've been warned, okay? If you're using those candy canes, make sure that the legs do not touch up against them because you can get a compression injury. So I pad them up generously. What else? You want to align the patient's feet with the level of their knees. See how it's nice and straight across there. And you want to ensure that the pelvis is level and not being pushed around, not tilted up or down. In other words, they're not hanging off the bed or being pushed up. All right. You want to keep both legs up at the same time and then down at the same time. There's also high lithotomy where the legs go up a little bit higher, and there's lower lithotomy where the legs can come down and flail out, depending on what surgery they're doing. And it's usually for like a pelvic exam or childbirth or rectal surgery. So what are our concerns? What are we worried about? We're worried about the common peroneal nerve. That is the most vulnerable in this position, and the caused by compression at the fibula head from the stirrups. These guys are super awesome. I wish everybody had them, but not everybody does. The sciatic nerve is from external rotation of the thighs and leg, and it can cause traction. And the saphenous nerve from compression by the leg holder and pushing on the tibia. So the obturator and femoral nerves, this is from pressure on the lower legs, can damage the femoral and obturator nerve. And you pad the posterior and lateral knees and the ankles to prevent contact with the stirrups or crutches. All right. The femoral nerve. The femoral nerve is in the pressure, is pressured by the pubic ramus with excessive thigh flexion. Remember what I said about putting up legs one at a time? If I put them up one at a time, I could stretch the femoral nerve. This arises from L2 to L4. I don't have pictures of these. I'm sorry. Let's see what I have next. Actually, do I have something? Yeah, I have a video of it. All right. Here, I'll go over the nerves real quickly and I'll tell you where they all arise from. So this is a list of nerves in the lithotomy position that we're worried about. The perineal, the sciatica, or sciatic, I'm sorry, the saphenous, the obturator, and the femoral. So both legs up at the same time. If you don't do that, you can stretch the femoral nerve. There's also the lateral femoral nerve if I let the candy canes push up against it, against the leg. The obturator nerve begins at the medial border of the psoas muscle. It travels through the obturator foramen. The nerve provides sensory perception to the skins in the medial part of your thigh, like, right inside your thigh. It also provides motor function to the hip and knees. So overstretching of the legs in high lithotomy can damage the obturator nerve and they will have numbness on their inner thigh. The sciatic is external rotation of the thigh. Say you put them up in the lithotomy and then you stretch them too far outwards. The sciatic nerve arises from L4 and L3. Injury is from the stretch or compression and ischemia. This is like pushing people too up. I got to tell you, I think maybe when we had people in the ICU and we kept them so sedated, and you see people rolling them on their side. These people don't do yoga. They're sitting in the bed. They're sedated. And I'm wondering if we didn't accidentally cause stretch injuries to nerves by rotating them up, and we would do it by ourselves, and we'd pull on a leg to help rotate it up. Probably not the best movement. I think that there is a lot to be learned of proper body mechanics. So if you damage, this actually happened to my sister, the sciatic when she was birthing her child, they put her in too high of lithotomy. And it caused her to develop a foot drop. So you get a weak flexion of the foot. So you're like, not that you drag a foot behind you, but I guess it could be that extreme, but her foot would like smack down when she tried to walk, and she just it never got any better. Once these nerves are damaged, they're not very forgiving. It's not like a bone or a muscle that can re-knit itself. It's like done deal, baby. All sensation with the sciatic, all sensation below the knee, except the medial aspect of the leg and the foot is impaired. All right, so the saphenous nerve, you get compression of the leg holder and the tibia, right? So he didn't pad up the holder and the leg was pushing up against it. You can get saphenous nerve ischemic injury. Damage will present with pain and numbness along the medial side of the calf. Now, the common perineal nerve is the most vulnerable nerve also. Well, I just said that the other one was the most vulnerable. So the common perineal nerve is a very vulnerable nerve in this position. And this is most common. It occurs in lithotomy and lateral position from the nerve being compressed at the fibular head, especially if surgeries are greater than 4 hours. It arises from L4 and L5 and also S1 and S2. And damage is the loss of the dorsal flexion and eversion of the foot. They can't put the foot they can't lift their toes up to the sky. I know I say these things like it's every day, and it actually is not, but if you're aware of them, if you're aware the candy canes are your bad people, you want to pad those up. You don't push people out of positions they can't normally do. If they can't normally put their knees up and spread their legs apart, if you feel any resistance, don't think that because they're on muscle relaxants that they can be pulled into a different position. Just obey. If you feel resistance, obey it. It's so easy to, here, this is a great video of people going in. It's so easy to say, if I just pull a little harder, I'll be able to go where I want it to go. Don't do it. So this is a video of people putting a patient in lithotomy. That's exactly how we do it. I love these girls. Now the left leg is a little bit further out, but it went in easily. Now of course this patient's wide awake because this is just a volunteer. And see how they're taking the bottom board out? Now, where do you think her fingers are? Her fingers are like right there, aren't they? So that board puts back in place. It could pinch the bottom of her fingers. And she's asleep still, so she's not going to complain about it. She's going to lose the tip of her finger off. Or I can pinch her buttocks area.
This is the lithotomy position. You have to have 2 people positioning because you need to bring the legs up together at the same time. So we're going to do that. 1, 2, 3.
Remember, for the large patients, well, good, you have large
Secure them.
outside, arms to the hands to the sky to rotate, protect the ulnar nerve.
And
If you
then the
have arms
bottom
out
of
to
the
the
bed
sky,
is removed.
arms at the side. And if you have a large patient, be careful of the safety belt pinching a fold of fat. All right, I love that video. It's pretty awesome. So the crushing, I told you about the fingers and the thighs and the buttocks getting crushed when that bed comes back up.
And the bottom of the bed
probably
is to go
both
down.
legs at the same for instance,
And the
stretch
patient's
injury
bottom
to
should
femoral,
be at the
obturator,
very edge of the
sciatic
bed.
nerves, and also
And
patting,
this is
patting
completely
with your
down.
friend here. Really, what
And
you need to
safety
remember is
strap across
just
the belly
obey
here.
a patient's
And arms out to the
limitations,
side.
and don't let somebody bully
We'll
you
wait till
into
it's down
pushing a
more.
patient beyond their normal range. If you feel resistance, you're not going to go any further. That's all there is
And
to
this
it.
is lithotomy.
So this is Trendelenburg, and Trendelenburg is really just a variation of supine position where the patient is tilted 35 to 45 degrees, head down. And this allows the pelvis to move up, which is really just for a surgical position. So the pelvis is above the head. So you want Velcro padding before you place in this position. And I kind of like this. Now, they're using these fins again. Again, I love these. It's like putting on ski boots, and it helps hold the patient in place. I like it even better if you have little Velcro padding here. They use these mats that hold the patient in place. They don't allow slippage. He's being held here. Now, what is the danger in this position? You guessed it. It is the brachial plexus. Look at these guys pushing down. If this guy pulls the arm, right, the humerus head will then pinch off those branches of the brachial plexus. These braces will push the shoulder, which is like the scapula and the first rib, to pinch off part of the brachial plexus. So we have to be very aware that if we shift it down, that we're not putting too much pressure right in this area. That's my main concern. So gravity will aid in the clearing of the pelvic area of the abdominal viscera. So it's commonly used when the operation is of the lower abdomen. This is a pretty extreme version of it. Patient's hands press against patient's innards press against the diaphragm and chest, and this, of course, is going to result in a lower stroke volume and the compression of the heart. So it makes it a little bit harder for us to ventilate them, makes it harder for the heart has to work a little bit harder, but at least all the blood is rushing towards the head, and I'm going to be able to adequately perfuse the brain, unlike if I went to the opposite way, where I was head up. I would have all the blood rushing to the feet, and the patient's head wouldn't be perfused, and I have to think of that hydrostatic gradient. So here, at least, my head's being perfused nicely, so we're not going to wake up with a cerebral ischemic injury. I think these patients are at a high risk also, as a side note, for aspiration. So if I know I'm going to go into this position, I don't care how your MPO status is. I don't care if you haven't eaten or drank for a week. I'm still going to drop an OG down you. Of course, when you're asleep, right? That is pretty much it. So the main concern here is your brachial plexus being damaged, and I've already reviewed several times the damage of the brachial plexus would cause numbness, tingling, weakness of the entire arm, including loss or weakness of hand strength. So Trendelenburg use of shoulder braces can lead to brachial plexus injury. Nice. So complication of Trendelenburg position includes increased intracranial pressure. Say you have a brain injury, this would not be the position for that. Intraocular pressure, as well as increased facial or laryngeal edema, which can lead to postoperative airway obstruction. Thank you so much. Here are my references over here. Well, that's my dancing skeletons. We can end with the skeleton, which is always nice. And there are my references. How awesome.